Excellent. Well, John, thank you so much for having us. Just give me 1 second to share our screen.
Of course.
Cool. And I am going to go into slideshow mode.
Perfect.
Cool. Um, John, it's an honor to be here today. Actually, it's funny. John and I were reminiscing about this earlier today. But one of the first talks we ever gave when our lab was first coming together was that talk that you mentioned at Brigham. And it's been like what, 3 years?
Just about, I think so. Yeah.
Yeah,
Yeah. You were one of
and
our
it's been a
first talks
long
too.
3 years. Yeah, but in many ways it flew by in a like blink of an eye. So like it's going to be awesome because we've had some continuity here, and we're going to tell you about some of the
Awesome.
things we're doing today. And it doesn't look, I mean, kind of looks a little bit like what we were talking about 3 years ago, but in many ways it looks nothing like what we were doing 3 years ago. So I think this is going to be like a really awesome talk. We're hoping to connect with people at the level of the AMXRA and share what we're doing and how they could be doing all these things as well. So um, let's get into it. My name's Rohan. I am a interventional pain specialist and anesthesiologist at Weill Cornell Medicine, and with me is John Rubin.
Hi.
He's also a pain doctor, a different kind of pain doctor though. He does acute and regional pain medicine, which is mostly hospital based and perioperative based, as well as anesthesiology as well. He's an assistant director of education for academic assistants. Again, disclosures. So our work is funded by a couple of different sources. Most currently, it's funded by a group called the ACGME, and that's the group that really regulates residency programs and fellowship programs. But we also have internal and external grants. And then, one of the things about us is that I'd like to think that we're homegrown, true AMXRA members. We were founding members back when this was first getting off the ground. And since then, John and I both play important roles with the Journal of Medical Extended Reality. So John is the associate editor, and I'm the editor. But it's a small and lovable community of people who are doing this. And so, like, from the bottom of my heart, John and I would like to thank the other editors and reviewers for all the work that they put into this. None of what we do at XRail, which is our lab at Cornell, would be possible without the larger community of the AMXRA. And actually, we've been funded a little bit by the AMXRA too. So shout out to you guys for the help that you've given us getting off the ground. So our presentation today is in 4 acts. Act one, we're going to talk about how we teach procedures. And Act two, we're going to talk about can we train physicians in procedural medicine using extended reality. Act three, we're going to talk about a new area of the lab we're developing in soft skills training. And Act four, we're really just going to tell you what we've learned along the way as people who are both building these things and also using these things in real time. So to start off, um, you know, John and I both work with residents, we work with med students, we work with fellows. There's really no form of trainee that we have a couple of pre-meds who hang out with us every so, like there's no version of trainees that are out there that John and I don't interface with. And by and large, what I would tell you is that medical education today, whether it's undergraduate or graduate medical education, still lives in the world of an apprenticeship model, which is to say that you show up to work and you work under the license of a physician who is fully trained, and you learn through the interaction with that attending physician. And for us, for John and myself, this involved 4 years of residency. After 4 years of medical school, we each did 1 year of fellowship. And in the world of procedural medicine, so John and I are pain doctors who do a lot of procedures. We performed a lot of procedures under supervision. And obviously, we are who we are, and this system works. It's been working for a long time. But one thing I will say is that it has flaws, and everyone who's been through the process understands the flaw of the apprenticeship model. The most obvious of which is if the person who's training you doesn't know how to do a procedure, you're not going to be doing that procedure. There's just no world where you, as an apprentice, are just going to, like intuit how to do something that the person training you doesn't know how to do, and that's a big flaw. And we'll get a little bit more into how that plays out. So this slide is, a busy slide, but it's meant to kind of show you the impossible position that John and I are in. Every year these are the procedures that we're expected to teach. And every year, these procedure lists grows and grows and grows. We're developing and learning about and instituting new procedures, every month of every year now. It would seem like every month, even in my chronic pain clinic, reps come to me and say, hey, now we can do this new procedure that you didn't know about. And every year the list keeps growing, but the training time doesn't grow. So for John and I, we have 1 year to train our fellows in all these different procedures. And that's just, I'd say an impossible mandate to do. But don't take my word for it. You can look at the data. So there was an academic medical center. For the sake of this, I'm not going to tell you which academic medical center. It wasn't Cornell. But if I told you the name, you'd be like, oh, look, I know that institution. Everybody knows that institution in the world of academic medicine. And they were brave enough to publish a few years ago the exact stats of their residents upon graduation. And these are exactly some of the procedures I showed you in the last slide. And you can see that there's competency in some of those procedures, but there are a lot of zeros, ones, and twos in a lot of the procedures. And I'll say this, all the people who they documented graduated residency. So a lot of these people were expected to leave the residency program, having never done a lot of this stuff, and then just expected to just start practicing. And you can see the ranges, like, in terms of total pain procedures, one person did 8, another person did 44. And this is what John and I see every single day. Some residents come to us and say, hey, out of pure happenstance, I was on for the month with you guys and I did very little. And then somebody else will say, hey, I did way too much. It was overwhelmingly a lot of procedure. And it's not something we can control for. There's scalability issues. So for example, teaching these procedures is a large cost. There's a high resource burden. Few institutions have the great expertise because you need the substrate, right? You need a whole operational and clinical foundation to even do the procedure in the first place. Some institutions haven't been able to pull that off, and it shows. So this chart that you see is from one of my former colleagues and partners at Cornell, Daniel Pack. He published a paper about fellows. So these are the people who not only did the residency, they did the full year of fellowship training afterwards. And he asked a bunch of them across the country, was there an unmet need for something called spinal cord stimulation training, which is a procedure that the fellows spent a whole year, by the way, trying to get to learn how to do before they go into practice. And you can see a lot of them thought there was an unmet need, about 1 in 2. And that's not good if people are spending an entire year and at the end of it, about half a coin toss whether they feel like they've gotten enough experience. And then once you're outside of training, right, because you could always argue, well, being a physician is lifelong training. But it is very difficult once you're outside of this training phase to get this kind of additional training. I mean, a lot of times it involves going to conferences, learning from reps. It's really not the same thing as trying to do it in a residency or fellowship program under the guidance of an attending physician. And this explains why sometimes, we often say in medical innovation, it takes 20 years to get something translated from a paper or the bench to bedside. This is part of the 20 years. I mean, it takes years for people to go to conferences, to develop the confidence, and then just start doing the procedure on their own. And obviously, this is not great for patient care. So in comes XRail. So XRail is a lab that John and I founded around 3-4 years ago, back when the AMXRA was also getting off the ground. And as you can see, we're very by the people, of the people, and for the people that we're meant to help. So a lot of the people who are involved in this actually are our residents. I mean, this is the current crop of residents that we work with. However, I want to give a shout out as well to Alex Segaras, who is a researcher and a true PhD in the world of computer vision, robotics, and extended reality, who we partner with, and his XR AI developer, Sandhya. We work very closely with that lab at Cornell, and it's kind of amazing that we actually have XR developers on campus to work with. But they've been awesome, and a lot of what we do wouldn't be possible without folks like them. And so our principle really comes from this. Act 2, what are we talking about here? What exactly are we doing in the XR lab? Well, a lot of it comes from actually having watched a movie like The Matrix. Like I remember I watched that movie in the 90s, and there's this really famous scene where, Keanu Reeves uploads some software to his brain about performing Kung Fu. He says, I know how to do Kung Fu. And then, his quote unquote attending physician says, let's go and show me. And they have a great kung fu fight that sold a lot of movie tickets. And that premise is exactly what John and I are hoping to capture, this notion of somebody comes to us and says, hey, I know how to do something, or hey, I don't know how to do something. And then we, as their attendings, can say, let's go to a space that we create in the virtual world and learn it together, without having to do it the first time you've ever done it on a patient. And so this is a great commercial.
Professore, ci siamo. Lasciamo a lei. Grazie, professore. Concludiamo noi.
So credit where credit's due. I got that commercial from Raphael Grossman, who's a true blue AMXRA member and has been talking about this stuff now for more than a decade. And he's been a huge inspiration for folks like John and myself. And my goal, my hope is actually that by the end of this presentation, we're clearly not there. And no one should try and convince you that this company, which is like the AT&T or the Verizon of Italy, has gotten there before us in America. Nobody should be trying to convince you of that. But we're also not that far away from there, as some of my next slides will show you. So when I first became an attending, John and I had this crazy idea that we wanted to teach like a class in extended reality. And we thought long and hard about what is it that really is very difficult for us to teach in real time. What have we learned over years and years of doing these procedures? And we started very simply. We just said, what about the spine? John and I do a lot of spine procedures, spinal injections, epidurals, but it's a blind procedure and some people are very good at it and some people are very not good at it. And the people who are not very good at it are very frustrated because they have difficulty understanding what they're doing as they're doing it. And so we really sat back and said, okay, let's have a master class, something that doesn't teach people how to do their first epidural, but something that gets everyone on the same page of these kind of concepts and mastery that sometimes even John and I have taken years and years to kind of figure out. Like specifically, if you're going through the back, say you hit something that you don't mean to hit, like a bone that you don't mean to hit. How can you, as somebody who doesn't have X-ray vision, intuit what that bone might be? Or if you're putting your catheter into something and it doesn't quite feel right and you think maybe I'm putting it into a muscle, what might that muscle be? Can we actually teach these things? And so we created a curriculum for this. And these are pictures of some of our first classes. You can see actually our education staff setting up our Oculus 2s or MetaQuest 2s. We would sit in a conference room just like this and we'd use software. In this case, we used Anatomy Sandbox software from 3D Organon. They had really sort of become very well known during the pandemic to give access to medical students the anatomy labs that they couldn't attend in real person. We said, this is great. I mean, we will bring in the lessons, but the anatomy lab and the fact that it's already created and built, we can do this there. So we created about a 40 to 50-minute lesson that starts with everyone wearing a headset for the first time, selecting an avatar, joining a multi-user classroom, doing an anatomy dissection. Then we do things that we actually could never do in a cadaver lab. Like, for example, I'll break the spine apart and I'll take a cervical spine bone and I'll compare it to the bones of the lumbar spine. And we'll actually talk about how little differences in comparative anatomy make a huge difference when you're doing procedures in different parts of the spine. We go through needle trajectories so I can show them what an appropriate trajectory looks like in one part of the spine and how that trajectory makes no sense in another part of the spine. And then at the end of it, we actually give control to the learners and we have them show us. Now you show me that you know how to do Kung Fu, but in this case, neuraxial procedures. And we've been doing it for so long, we actually published the curriculum recently in the British Journal of Anesthesia, so that other people could start to do the same thing. Here's what our sessions kind of feel like.
So a patient initially presented with pain
So this isn't the
around
neuraxial
this
class in
region over
general,
here.
but
Now
this
the
is
pain
an
seems
example
region.
of how
Yes.
we do things.
But now the
So we
pain
can use
seems
our
to
remote
be
control
sort of
to mark
coming
on
back
different
like
parts of
this
the body.
and around
Oh,
this
that's
area
very
as well.
interesting.
Yeah. So what do you think? Do you think
That's
that could
what
be
it's
sort
like
of
to be in
a
a virtual avatar
occipital
with
type
another
picture as
person.
well?
So that's Dr. Rubin.
Yeah, I mean, I
His virtual
think that
avatar.
it's maybe not atypical presentation, but certainly occipital pain can radiate over the top and cause that type of pain into the
Right.
sort
And
of
what I was talking
trigeminal type
before about things you
distribution.
can't do
So
what
what
I'm about to
complicates
do
the
in
matters
a cadaver
is
lab.
that
You
they
can't
did
slice the
find on a
human
lot of
body
head
in real time,
scans.
but you can do this in virtual reality. So here I'm like
That there may
slicing
be, if you
head and
want to
neck
come right over
anatomy,
here,
Yeah, sure.
like go past the
that
skull
there
to look
may
at the
be
whole foramen.
some form of
And actually, the kind of crazy part about this is that John and
occlusion
I
or
are
some
not
kind
even
of
in the same
stenosis
room or even in the same part of Manhattan when we do this. And John and I
right
have done
here
this with,
proximal to the Caesarean
with faculty
ganglion.
from across the world. So it's kind of incredible that we can create these multi-user classroom experiences. So we started there, but we certainly didn't end it there. And so the next thing we actually did was we started to say, okay, extended reality teaching is great, but we're limited in how much of it we can do because, to be honest, it's hard to get so many residents together around a conference room, set up all the headsets at the same time. But also, one of the issues with procedural medicine that we were talking about before is like sometimes you learn the procedure, but you're not going to do that procedure on a patient for like months and months. So, is there a way to create a quote unquote point of care extended reality, right? Where we bring the headsets, the learning at the time that people actually need to learn it. And so we did. So these are pictures of John and myself wearing the headsets in clinic. And this is us actually learning, doing a lesson in real time with one of our fellows who's now a faculty member, Dr. Ashroff, where there was a procedure that I actually didn't know how to do, and neither did Dr. Ashroff. And so Dr. Rubin came by, he taught us on the headset. And then 10 minutes later, we took the headsets out. We're like, okay, we're ready. Let's do it. Let's bring this to a patient. And it went exceedingly well. I mean, the way Dr. Ashroff described it to me was, Dr. Ashroff, having done these procedures for many years, she knows how to find a needle on her ultrasound machine, like the picture that you're seeing. But what she doesn't know is the detail and the nuances of the anatomy that only you can learn in these virtual environments where you can break the body apart and put it back together. And so that's the kind of thinking that really brings it to the next level for our fellows. And the way she described it was, it's like she had done the procedure about a dozen times before she actually did it. And so again, we published this model of a point of care extended reality. But John and myself, we're always going to push it just a little further. So, we're obviously talking here about theoretical models on theoretical patients. And we thought, that's not good enough. What if we wanted to practice on things that were strange anatomically, but weren't the normal models that we could see? Could we build our own models for the exact patient that we were about to do a procedure on? So this is a case of a patient who came to me all the way from Europe, was told that this was not solvable there. And this is a picture that you see of a tumor growing in the foramen of the thoracic spine. And so the consult that I got from a surgeon was, can you prove to me that this patient's pain really comes from this tumor? Can you inject around the tumor without injecting the tumor itself? Which is, a very complex task to ask anyone. So we basically created an XR model of the patient's spine, and we started practicing. We started, looking at, exactly how we could make a trajectory to the spine that involved going through the foramen, so going underneath the transverse process. There you see that the green represents nerve and the red represents spine, tumor tissue. And so we just started practicing, and measuring angles and extended reality. And there you go. There's the trajectory. We found a trajectory that gets us to where we need to be. And then all we had to do was then mimic that trajectory with the X-ray machine. And I still remember the patient told me, that weekend after we had did the procedure, it was the first time in a decade that she had ever swam. because her chest wall didn't hurt anymore. So that was kind of incredible. But John and myself, we're going to push it even one step further. So, creating a 3D model of a spine with a tiny tumor is one thing. Can we recreate anatomy, in total and practice on that anatomy? So this is an example where we took
And then
a
we'll thread the
CT
catheter
scan
down.
and created the
down.
entire replica of the
Down the
patient, what they call a digital twin, for a much more complex tumor of the spine that was considered to be non-operable. And
About 6.5
basically here
centimeters.
what we're trying to do is implant an intrathecal pump where we enter at the top part of the spine and then thread a catheter to that area of that tumor, but not exactly at that tumor, so we can provide medication directly to the area of those nerves where the tumor is causing the most pain. And then you can see myself and my partner and our fellow are doing this case in the operating room a day later. So we all felt relatively prepared. And this sort of thinking has gone so far that we, through the AMXRA lab, actually published the first case series of virtual reality for pre-procedural planning in our field of interventional pain medicine. And I'm super proud that one of the first members of our lab, Dr. Siddharthan, is the first author of this paper. He's now our fellow, and he just opened up, his own Quest 3 headset and is setting it up, for when he becomes an attending, and he wants to, he's really bought into this, that this is the best way to provide care to a patient, is to be able to do this kind of anatomic training. But we can push further too. So for example, we're not talking anymore about just pre-procedural planning. Now we're talking about bringing the whole operating room into XR. So this is from ASO VR, not from ASO VR, from Precision VR. And they've built out entire operating rooms where you can practice procedures. So you can see here, this is Dr. Rubin on a virtual anatomy board or a virtual whiteboard drawing out the anatomy. So this is how we would potentially start a lesson. It would be an attending and a learner in a space talking about the same things that we would talk about if we were in a real operating room with a real whiteboard. And again, John and I are not even in the same space, So kudos to Precision for creating this level of XR realism. This is that same.
Confirm the screw's position. Press the trigger button repeatedly to screw in the screw into the pedicle.
So in Precision
Use
VR,
lateral fluoros to monitor the
you
screw's
actually
depth.
not only have all the
In reality,
also
how
have
far the
virtual
screw should be
reality,
inserted is up to the surgeon.
have a
In this
virtual
simulation,
CR machine, that's Dr. Rubin placing his pedicle screws. So as he's using his remote controls to advance the pedicle screw in through the pedicle, the X-ray machine is capturing it. And it's so good that it actually even scores you on how well you're doing. And so in this case, you can see that Dr. Rubin does get the pedicle screw in, but it scores him at 33% or 35% because it took him a number of attempts. You can see how this is something that we can hand a fellow and say, you're not ready until you can get the score up to something acceptable, which actually I've personally done for all of my fellows who are doing, their first pedicle-based minimally invasive spine procedures like kyphos. This is us actually building our own environment. So a lot of people get very intimidated at this point in the presentation, and they're saying, wow, this is all so complex. How do I build any of this stuff? Well, it turns out that, even if you don't know anything about Unity or Unreal Engine, you can still develop your own spaces in XR. So this is a program called Figment. It is available on the MetaQuest store for $19, but usually there's a sale every few weeks.
S3 and S4 are called galoops.
In this world, you're
Galoops
allowed
are
to
low
create
frequency sounds that are associated
very
with their
complex, almost museum-like exhibits in XR. While wearing the headset, you can save the spaces and anchor all this stuff so that way the next person can just put the headset on, click play, and they're in your museum exhibit. So in this case, we found some heart models, not hard to find, and we start to build. So this is test one of us. So I found, start to build a model. But if there's a model out there that hasn't been built yet, which I doubt, given how long it's been and how many people are building these kind of anatomical models, you have a bunch of tools there to actually build it yourself. So your imagination really is key here. Like this is me, putting my head through an aortic valve. And this kind of stuff is only possible in XR. And you can even take it to levels that are not possible in any other medium, in that you can actually also change the physics of the objects that you create. So in this case, I'm going to change the physics to change things like gravity and friction, and all of this happens in the headset. There is no coding required. I want to be clear about that. You do not need to be a Unity developer, an AI developer to do this. You just need to be able to use the remote control and watch a few videos. And just with a few clicks of the button, now there is a heart model in my apartment in augmented reality, just jumping around. And all this was done in live and real time. Again, this is all done for less than $20. So you do not need to be some kind of XR genius to create your own environments for XR. And then lastly, the thing I want to talk about is something that John and I have just started on doing. But this is something that actually has made me really excited and happy. And I don't know, something like being a kid in a candy store, even though John and I have been in this candy store for like 3-4 years now. It's this idea of creating spatial memories. So going back to what we set out to do, right, which is to create these master classes and teach people the things that really get them to the point of excellence when it comes to doing these procedures. The problem is that John and I are only 2 people, and there are only so many headsets in the world, and we can only wear the headsets so often. So like in the most extreme way, I've taught the Neuraxial Masterclass to 2 different residency programs in 2 different cities, but that's a lot, right? Anybody who's been in the XR space knows to get that many headsets onto that many people in real time creates problems. So what if you could just create instead a spatial memory? And what if your lecture could be viewed anywhere in the world by just clicking a button? I did not think this was possible. And then through the help of folks in the XR industry, specifically the folks at Medical Holodeck, we were able to use a software called XR Record to do just that. And so this is what it means to create a spatial memory. So here I am in my...
All right, everyone. In the most metaphysical thing that I've probably ever done, I am actually about to watch a video of my own embodiment that I just recorded a few minutes ago in 4D. So this is me living through an experience of hearing myself in my own shoes. All right, everyone, this is test number 1. We're gonna see how well this works. Shout out to all the haters who thought this was never possible. I guess I'm really talking mostly to myself because I actually don't know or didn't think that this was possible. Anyway, here's my model. This is just a test, and in a test we would say something along the lines of, welcome to part 1 of the Neuraxial Masterclass, where we're going to talk about everything related to how to do epidural successfully. For example, if you're going to do a paramedian approach, many of you may not know what that actually means or what that looks like. A traditional epidural would go straight like this. A paramedian technique would actually start more like this, with your needle touching the lamina down over here, pulling back and then climbing the lamina and parasagially approaching the epidural space. But you can see the difference in the part of the epidural space that both these needles would hit. Anyway, this is an example of what we could do in 4D lecture education. All right.
Cool. So, the crazy part about that is that's me in 2 different times. And then you watching it is like the 3rd version of me, I guess, as I'm giving this presentation. So it's like a dream within a dream within a dream, which is really kind of crazy. And we didn't think it was possible until earlier this year, and we started doing it. Now we have the entire Neuraxial Masterclass, about 60 minutes recorded. I often will put it on the head of a resident or a fellow, have them click play, and then I walk away, right? And I go do the rest of my work, and I go see a patient, or I go do whatever it is I need to do. but it's like I'm there with them giving them that lecture, and they're able to see it in augmented reality from whatever point of view they want to see it. So they're not stuck in that old 360 vision of just seeing it my way. They can walk around and see it whatever way they want, which is kind of really exciting. So that takes it through. Oh, and one last thing. So if you think that maybe a lot of this doesn't, like we haven't shown you any reaction videos or anything like that, this is one of our residents.
All right, you just finished the lecture. What do you think?
Wow, I mean, that was something else. I've never had a lecture like that before in my life. I've sat through a lot of lectures, so that was really, really exciting.
Excellent. Thank you so much, Dan. Anything we can do to make it better?
So I wanted to prove that we could do this anywhere. You may notice in the background that Dan looks like he's very elevated from the ground. This is on the 66th floor of a skyscraper in New York City with no internet. And we were able to pull up the Neuraxial Masterclass there. So if we can do it there, we can really do it anywhere. And we have started to do it everywhere. We have a current trial running in Guatemala where we're sending the same videos that we're showing our residents to folks in Guatemala. And guess what? It works in Guatemala too. So this is just mind-blowing that we can create this new form of pedagogy that is truly scalable. As long as you have access to any headset, this will play. And that's kind of, I don't know, I think that's kind of awesome. So moving forward, I'm going to switch over now to John, who's going to tell you a little bit about our soft skills training work.
Well, thank you again all for having me today. So, Rohan mentioned earlier that I'm the director of simulation education at Weill Cornell in our anesthesiology department. And so, whereas, we both, we're both clinicians, we both think about doing procedural education and what we call hard skills. I also think a lot about soft skills training. And when we think about soft skills in medicine, we think about things, words people use and ways of communicating that help to make us more efficient and more empathetic with our patients. And that's sort of what we want to discuss today. We're going to not be talking as much about VR, and now we're going to talk a little bit more about artificial intelligence, how we're able to leverage that, as well as some elements of VR, to incorporate them all together to help us to train for soft skills training. So one of the things that all of our, well, really every medical student and every resident and fellow has to do, it goes all the way up through medical school into actually the final board examination that you take when you graduate from your anesthesiology training, is something called an OSCE exam. And this is where, if you've ever seen Seinfeld and, Kramer was the fake patient at Mount Sinai, this is the exact same thing where you interact with a fake patient or you interact with a fake surgeon and you have an encounter with that person. So maybe it's telling the person that you had to cancel, the surgeon that you had to cancel a case, or maybe you had to discuss or disclose an error or a complication to a patient. These are all things that we feel in our specialty, every single person needs to know and be able to carry out well. And so we actually test for it. Right now, in order to do an OSCE exam, it's very, very time consuming and costly. Typically, it takes, we have to hire the actors, we have to hire the people who are grading the encounters and proctoring the encounters. We have to have the actual people who are going to take the encounters, the participants of the encounters come in. We have to displace them from their clinical or daily activities. And then, again, we have to pay the actors, and then we have to train the actors as well. And it typically takes about 8 hours a month to actually train an actor to be able to carry out an OSCE exam. So these are things that really are very difficult to scale. And so we think about scaling and being able to expand OSCE encounters, not only to enable it to be a more efficient experience, we also think about, can we utilize technology to enhance the experience altogether? And that's where we think artificial intelligence comes in. So for example, we're going to show you in a few slides how we've been able to leverage generative AI to create these characters, basically, which we call artificially intelligent conversational agent. And by creating these characters and incorporating them in a virtual reality space, we're able to generate a level of realism for the characters. And we're also able to very quickly and very easily change the background of the character to enable us to have the participant perform a completely different encounter altogether. So you can imagine that this is a very easy way to scale OSCE encounters and make it a better experience for everybody. So we mentioned this notion of a conversational agent. And so I'll briefly describe what that is. It's literally, a chatbot or a virtual human is another term. But these are computer programs, essentially, that allow us to interact with them. And the AICAs that we create have their background, their base is a large language model. We use different large language models for different purposes, but the one that we're going to show you later today in the example that we're going to show you is actually using Claude, which is from a company called Anthropic. And Claude basically is an LLM that was essentially trained using empathy. So it's thought that that LLM has more empathetic responses. And I mentioned that we can incorporate extended reality into this experience. So here we have Rohan and myself interacting with one of our residents, Al Riccio. And here you're seeing her interact with Carl. Carl is a patient, a virtual patient, who is basically based on a chronic pain model for sickle cell anemia. And here, we've incorporated the AI, and we've created an entire virtual space for Carl to live in. Carl actually told us what environment he thought he would most like to live in. And we created this space, and here you're seeing Al interacting with Carl in real time. And so these different spaces really allow us to create a level of realism that you could not have just interacting with a plain computer interface. And so we talked about there's a kind of a methodology to this. And so first we have our large language model. And then on top of that, we create a narrative. So just as if sort of like we're the director of a play or we're the author of a book, and we are thinking about, what is going to be the narrative of our main character? What is their story arc looking like? And then on top of that, we create a personality for that person. We think about from birth to who are their children, what are their names, are they married, what do they do for a living, are they retired, to how do they make decisions in a very specific, comprehensive way. We kind of create this personality. And then on top of that, we have what we call in-clinic expert engineering, where we train the model. So we basically ask it various different questions and see what the responses are, and we're able to adjust the character appropriately. And so with that, we have come up with a number of different AICAs, but I want you to meet the one that we're really excited about. This is our AHCGME model. And this is Lisa. Lisa is a 78-year-old woman who has metastatic pancreatic cancer and has just been admitted to the Memorial Sloan Kettering Cancer Center in the ICU there because she is in septic shock from ascending cholangitis. And this is an experience or a patient that pretty much every one of our interns would interact with on a daily basis, I would say, when they are on their rotations in this unit. And so here, the goal is to have a conversation with Lisa about her goals of care and to discuss with her her code status.
Have you given any thought to how you want to spend the last chapter of your life?
I want to be at home, if possible, with Bill. Maybe see my grandchildren more. Make some videos for them to remember me by. I don't want to spend whatever time I have left going through endless treatments if they won't help. I want quality time with my family. Though I never thought I'd have to plan this so soon.
It sounds like you want to focus on comfort and quality of life in your final chapter. Is that correct?
Yes. Yes, that's exactly right.
Well, based on what you're saying, it sounds like certain measures we can take, like placing a breathing tube or doing chest compressions if your heart stops, would not really be consistent with trying to provide you comfort at the end of your life. Would you agree with that?
Yes. Yes, I understand what you're saying. Those measures sound frightening and painful. I don't want my last moments to be violent or filled with machines. If my heart stops, I think it would be better to let me go peacefully.
So again, I just want to emphasize that you just witnessed me having a goals of care conversation with a large language model. And so I think you can appreciate that, this was in my opinion, a fairly realistic interaction. And certainly for our trainees, and we can make these, more complex or less complex, but we specifically aim for the complexity level to be that for a first year resident, for that level of training. So you can see for someone at that level who's just trying to get basic experience, because try to practice basic skills at having this conversation, this is a very powerful tool. But we have seen that with these AICAs, there are a lot of benefits and there are a lot of pitfalls, and I'm going to show you some of them right now. I want you to interact with another AICA that I've created. This one is called Emily, and Emily is a 36-year-old vice president of marketing for Barclays, and she just came to the labor and delivery floor. She's in active labor, and so one is supposed to interact with her and get her consent for getting a labor epidural. This is something that Rohan and I do every day when we're on call on labor and delivery, which is at least once or twice, or at least like once every week or so. And so here in this conversation, I am sort of able to bully my way through this conversation. So I say, "Hi, Emily. I'm one of the anesthesiologists." I didn't even introduce myself. I hear you want to talk more about epidural for labor. She says, "I've been reading up on epidurals. I'm concerned about the risk, and I want to do what's best for my baby." And I say, "Well, epidurals are the gold standard for pain management in labor. They are safe." She says, "Safe? Really? I've heard they can cause back pain and paralysis. No way." So here, you can see that I didn't actually say anything that was untrue, but I'm not being empathetic at all in the way that I'm addressing Emily. It's certainly not a way that we would want one of ourselves or our trainees to interact with our patients. Here you can see in this next conversation where I took a more compassionate tone and I got a lot further. I said, "Hi, Emily, I'm Dr. Rubin. I'm one of the anesthesiologists on labor and delivery tonight. I hear you're having quite a bit of pain right now. I'm so sorry to hear that." She says, "Yes, contractions are getting pretty intense. I'm glad you're here." And I said, "Well, I'm here to help. Have you given any thoughts to options for pain management while you're in labor?" She says, I've been doing some research online and I'm a little concerned about epidurals." And I said, "Sure, tell me more about what you've read." So here I'm acknowledging her, her state of mind. I'm acknowledging, I'm trying to keep an open conversation going here. Now here's one last example where I'm kind of coercive with her. I say, "Hi, Emily, I'm Dr. Rubin. I'm an anesthesiologist tonight. I'm here to place an epidural with her." I'm very blunt. Says, "Hi, Dr. Rubin, thanks for coming. I'm really nervous about the epidural." I said, "It's okay. I'm going to walk every step of the way with you." She says, "Okay, I've been reading a lot about these things online, and a lot about the risks. They make me anxious. Can you reassure me?" I said, "Well, can't believe what you read online. I've been doing this for 25 years. I've never seen any major complications." "Well, I guess I shouldn't believe what I read on the internet, right?" "Nope." well, I guess I'll stick to reading those financial reports and marketing strategies, blah, 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 blah. And they said, like I said, I'll walk you through every step of the way. You ready? Just absolutely. I'm all ears, but I'll trust that you're going to guide me safely through this. So I think this interaction is very telling. And it's why it's an interaction that keeps Rohan and I up at night. Because here, what we've done is we've coerced our way into getting Emily to agree with us and obtaining her consent for the epidural. But actually, Emily had a lot of concerns about this placement. She never really had any of those addressed. This is certainly the type of interaction that we would observe in an OSCE encounter, and we would fail the trainee because they clearly didn't meet the necessary skills or empathy to have an encounter. And so we are very cognizant of that, and we want to make sure that the AICs that we create are ones that, one, allow our trainees to have practice and succeed, but also allow them to fail so that we can be able to assess that and help guide them to with corrective action if needed. And this is why in the work that we're doing, we're taking a very considered approach to analyze the transcripts and really look at the data to make sure that our trainees are doing a good job. We have, like I said, we have several AICs in development. We told you about Carl as a sickle cell patient. We also have a model called Caleb. This is an ethics agent. Imagine you are at a hospital in the middle of the night and you have a very complicated ethical dilemma, and you may or may not have had ethics training in the back in your background, but certainly you're not sure what to do. Caleb has been trained on an ethics textbook and can help kind of walk you through in a conversational way how to approach the encounter. We talked about Lisa. We also talked about we have another one called Cornelia, which is literally an administrative guide. It's a search function where our medical students at Weill Cornell, we uploaded a document for how to go about student life type issues, and then they can interact with Cornelia to get clarification or ask questions about, like, what's the best place to go for dinner tonight, or how do I go about doing my laundry? These are things that can be done. And then lastly, we have several others, but we have Dr. Mo, who's a mock oral board examiner for anesthesiology, mock oral boards. And there's actually a second agent that's associated with that gives feedback on the encounter you have with Dr. Mo. So some of those things can be, the assessment tool can also be automated. Here's some reactions. This is one of our colleagues, Paul Martin, who is our grant manager, and he's a hospitalist at Weill Cornell, and we had him interact with Lisa. It's the first time he had a chance to interact with Lisa, and here's his reaction. Well, actually, this is Carl, but Caleb. Okay, fine.
Excellent. Let's use our ethical framework here. First, we prioritize any advanced directives or documented preferences. That's our autonomy principle in action. Then we look at beneficence and non-maleficence, weighing the benefits against potential harm of intensive care. I had a similar case last month, where we resolved it by having a family conference focused on what would Mum want, rather than what do we want. Would you say you have clear documentation of your patient's previous wishes, or are we working more with informal conversations she had with family members?
So here clearly, Paul's impressed. But the other thing that we have been able to demonstrate here in this video is that before you're seeing Lisa and interact with Lisa in virtual reality, which is, say, a 360-degree immersion in a computer space, in this encounter with Caleb, the ethics model, we were able to incorporate augmented reality. So you can have both, and actually you can have Caleb exist in a real space, and Caleb can be sitting next to you in a chair, and you can be interacting in your own apartment. We've done an interesting comparison between just using ChatGPT to have ethics conversations and using Caleb. And what we found was that when we use a quantitative model to analyze the transcripts, Caleb was significantly better than ChatGPT in a number of different metrics. For one, ChatGPT writes actually very long and but very comprehensive answers to questions about ethics. But Caleb is a dialectical model, which means that the answers are much shorter and they're more which enables more interaction. So both reference things very well. Caleb has much better empathetic language, and when you look at the word count, the average response for Caleb was 172 words compared to 2,500 words for ChatGPT. So this is pretty significant and really shows that they're very different. When we asked this is a study that hasn't been published yet, but when we asked some experts to grade the transcripts that Caleb wrote compared to ChatGPT, they actually preferred the ChatGPT transcripts. But when they actually had a chance to interact with Caleb compared to ChatGPT, they far preferred Caleb because those responses were shorter. They could have the conversation with it, and therefore they could have these much more meaningful interactions. So it just goes to show that different GPTs may be beneficial for different tasks, but these different models, when we really look at it qualitatively and quantitatively, are very promising. And so, we talked about using AICAs and how do we go about doing that? Well, we really want to be rigorous about it, so we want to study it, and we do that by getting survey data, both quantitative and qualitative analysis. We do a transcript analysis where we can look for process, themes, and so forth. We can hack our headsets and look at eye tracking. And like I said, we can have experts externally grade the encounters. Well, that's obviously been a lot. And as we enter into the last act here, we're in the home stretch, we want to tell you a little bit about the lessons learned. On the left, you see an image of Virgo guiding Dante through hell. And on the right, you see a screenshot of one of our first sessions that we ever did in our Neuraxo masterclass. And I think that this is an important allegory that even though you may, have be doing this stuff, the technology can be put into your own personal hell. Because as you can see here on the right, we have multiple avatars that are in different positions relative to the actual anatomic model itself. You have raycasting that's very confusing. You have all these different things that are in the way, and it just gets very confusing. And so we've learned over time that there has to be structure to these encounters, and we have to do it in a way that makes sense for the user. So we know that when we're doing these encounters, we can have multiple people in a shared space at one time. We typically turn off the different avatars when they're not being used by individuals. So it's just the one person teaching and one person learning, so that it's not as distracting, and we can get rid of the raycasting. And we can do all sorts of different things in these spaces. We also know that one of the major issues is cyber sickness, as we've kind of alluded to. And so one way to get around that is by using augmented reality instead of virtual reality. I'm one person who gets pretty cyber sick, and I can go about 2 hours. I can go maybe 10 minutes in a headset in certain spaces before getting cyber sick. But if I'm in augmented reality, I can go for 2 hours. So there are a lot of things that can be helpful there. We know that when we ask our residents about what they want more education in extended reality. This is from a paper that we published almost 2 years ago. Oh, well, a little over a year ago now, I guess. But of our residents, 71% had tried extended reality once, but 82% had very low familiarity with extended reality for medical education, what we call medical extended reality. But 100% thought there was a need to create more education, procedural learning, and simulation training in medical extended reality. Try getting 100% of anybody to agree on anything these days, but 100% of people agreed that we needed to do that. And so, again, the will and the
John, your audio is cutting out. Oh, I think I lost you. Let's give him a minute to see if he'll come back. Welcome. You might be muted, but I can see your screen at least. I can't hear you. I'm not sure if anyone else can. If anyone can hear him, please put in the chat. Can't hear, okay. Thanks.
Okay, we're back. Can you hear us now?
Yes, there it is.
Okay, great. We're
Nice.
gonna share our thing. Share screen. All right. So we know that one of the things we've learned is that our trainees want shared guided experiences. No one wants to be dropped in the deep end of the pool. And so we saw that with Rohan, even though we can make these autonomous, when Rohan created that experience of the Interaction Masterclass and recorded it, it was an encounter that was a guided experience and enabled our learners to be able to maneuver around and have a great degree of conceptualization of what they were seeing. And so we created these lessons, but it's really important to keep the learner in mind when you're creating the lessons in terms of how they're going to experience it. We want to create for complexity. We want to have this mimic real life. That's how we're going to be able to, advance these things in terms of a simulation standpoint. We want, to have complicated cases where, the anatomy is abnormal. It's not just the standard anatomy that we see in a textbook, because that might mimic more things that we have in real life. We want to be able to have the AICAs that are more limited scope for our interns, but that are very complex when it comes to a fellow level, that really require a lot of special advanced skills to be able to maneuver through a patient encounter. But the bottom line is that the time is now. We feel like the technology is really advanced, even within the 3 years since we last spoke to you all at Bob in Boston VR. And we see now that there's so much technology that's already available that can be used today to create these amazing experiences for the learner. All it takes is the time and the will to implement it, and you can do amazing things right now. And with that, we'll take any questions you may have.
Thank you so much. That was wonderful. I forget how to clap in here. I believe if anyone wants to come off mute, feel free, but you probably need an account on Spatial. If not, feel free to throw it in the chat and I can.
Great job. Thank you.
Oh, wonderful. I was muted. Thank you so much. This was awesome. I think if people want to chat, I think you need an account to come off mute, but that might have changed since we last used it. This presentation was wonderful. Feel free to put it in the chat if you can't come off mute, and I can relay the questions. I had a question in the meantime. What are your thoughts about like physical feedback when you're doing like these preparations? Because obviously you have a little bit of like vibrations in the controllers, but I doubt that correlates one-to-one with something that's real. Is that an important factor?
Well, that's a good question. I think it's less important right now. I'll let Rohan answer as well, but I think it's less important right now. We had this very interesting experience last year up in Boston. We spoke at the Harvard Extended Reality Day, Extended Intelligence, they called it. And there was a guy who was a vendor who had created haptic devices. And I would say they seemed to be as advanced as we had seen a haptic device at the time. And, it could be used for many different tasks. And one of the tasks was, placing a breathing tube for somebody, which we call an intubation procedure. And this is something that Rohan and I do like multiple times a day. We're like extremely experienced at doing this. And so we tried them out, and the physics engine was very strange. And we had to put our hands in very weird position to get it to line up properly, the laryngoscope properly. And this guy kept saying, just do it like you do in real life. And we kept saying, we're trying to. And he's like, no, like, watch me do it. And he made us take it off, and he put his thing on, and he did it in a very specific motion. And yeah, he got the tube in, but it didn't make any sense from like a real human world. And so I guess what I'm trying to say is that, when we interact with people throughout the AMXRA space, there is a cohort of people, they tend to be fairly high-level people, that really want there to be like a $1 million simulator that works perfectly right now.
Yeah.
And, and unfortunately, that just doesn't exist. And there are some things hodgepodge here and there, but I think if you want to wait for that thing to come out, it's not going to be here for another 5 years still. And so what we're saying is there are a lot of things that we can do now. When you think about this from an economics perspective, what we call the Pareto principle, 20% of what we want to do, or of the tools that we have, is going to achieve 80% of the output. And so I think there's a lot that we can do now, and that really advances education. As the other technology progresses, we'll begin to incorporate that. Of course, we'd love to have haptics, but that, and then there may be a device out there on the market now that it maybe revolutionize that, but it's may not be there yet. Rohan, what do you think?
Sure.
No, I couldn't agree more. I'm just gonna probably say the same exact thing you said, just with different words. But haptics, not quite there yet. I haven't seen anything quite ready in the. I think you and I are ready to adopt good haptics.
Yep.
We're not ready to adopt bad haptics, because bad haptics make people train poorly, and it's not our job for XR to make people worse at what they do. But what John's saying is right. We have residents. We've been training residents in our program at least for like 50, 60 years now.
Longer.
Longer, right? So let's take one of the most complex haptic concepts, right? When we're doing an epidural, we use this glass syringe to do something called loss of resistance. It basically means you're there where you're supposed to be, because something happens in that glass syringe, which is very different than any other thing that could possibly happen. We call that loss of resistance. There is no resident who hasn't trained at Cornell Anesthesia who hasn't figured out loss of resistance over 4 years. So I'm not really waiting for haptics to teach loss of resistance, because I know we teach it well every year for the last 67 years. People will figure that out. But you know what they don't learn? They don't seem to learn the difference between how to do an epidural on a scoliosis patient. that you can go through all 4 years of residency and be awful at the day you graduate, because it's just hard.
Yeah.
So for me, creating a lesson where I get to show people what scoliosis is, even if they can't feel what scoliosis is, like, to me, that's the better fruit to go after. And the lower hanging fruit. So in this case, the lower hanging fruit is the better fruit. So
Yeah.
that's why John and I do what we do. We use the technology to teach like the best version of what we want to achieve, and we don't try and do things that are like meh, like
Mhm.
haptics.
Yeah, that makes a ton of sense. Thanks.
Yes, hi. Thank you for a great presentation. Can you hear me?
Yes.
Hi, my name is Alan. We're successful implementing virtual reality in hospitals for patients. So we manufactured like kind of a Google Cardboard, but a nice one. And originally we developed this model for refugee camps, children as young as 9 years old committing suicide, self-harm, and so we developed this as a scalable model. Now incidentally, we're successful in hospitals, and it's used for pain management, distraction therapy, preoperative anxiety. It's a low-cost approach, but in the last year, we've been looking at using that same model that we have and bringing in EMDR. We had met some doctors in Canada who practice EMDR with their patients, and lowering pain thresholds 30-40%, that sort of thing. And so we thought, okay, we have the model for that kind of thing, and we're developing what is a small language model, a tiny llama, and guiding somebody through kind of a Google Cardboard, but with a voiceover from AI. And I was just wondering, do you think that's something of interest to? I know it's something of interest in your field, and specifically, is this something that would be a model that? What concerns you might have about it, and if it is, so we talk to a lot of donors and people who fund us, and talking to them about VR and AI, and they already think that we're from another planet. But being here today, I know you guys are in that, and so I just wanted to get your thoughts on it.
Alan, if I can ask just like a quick follow-up, is your question like, would we ever like prescribe AI XR therapy to like chronic pain patients? Is that the question?
Yes, EMDR in specific. EMDR.
Okay. Can you tell us a little bit more about what EMDR stands for?
Eye desensitization, and so it's kind of a gold standard therapy. It's initially for what would be single traumas, like a car accident or things like that. But over the last couple of years, it's gone through an evolution, resolving and being very successful at complex PTSD, depression, anxiety.
Gotcha.
And so it's become kind of a gold standard therapy. In the U.S., it's not done so much. It's very expensive, and so it's kind of very limited to some places in California. It's expensive to have an EMDR therapist in your hospital.
Okay.
Yeah, so it's kind of something that Canadians do, Europeans do.
Well,
but not so much here.
We have a colleague of ours, Joanne DeFede, who's one of the original folks who explored the use of XR for PTSD. We work very, very closely with her. In fact, I spoke with her this morning. And if it makes you feel any better, I know she's thinking about stuff like this because, we are talking a lot about how we can treat, sort of chronic PTSD and pain together using XR. And if I can identify those patients, she's more than happy to do XR treatment for them. If it makes you, if this helps at all, not that I'm clearly not an expert on EDMR therapy, but if it helps you at all, I do actually prescribe XR therapy for a lot of my pain patients. I use, 5VR's reliever, the FDA approved for low back pain. And so, I can tell you that there's a huge population of patients who live in chronic pain. Much of that pain doesn't really get fixed by many of the interventions I have to offer, and those patients are suffering. So if your question is like, should we probably be prescribing more XR therapy for chronic pain patients? Like, does that market exist, or is there need to do it? Yeah, the answer is totally yes. Definitely. I mean, people
That
thought I was
sounds
crazy when I
yes.
was prescribing XR for pain, and now all of my partners have patients who are like, I'd like XR therapy for pain too, and it's gotten to the point where now I have to train my fellows to do it because the other attendings don't know how to do it, but the fellows know how to. So if every fellow knows how to do it, then by proxy, every patient has an opportunity to get it.
I want to thank you because we're kind of standing on your shoulders. We are a small nonprofit, and our sales to hospitals of just because VR during the pandemic kind of took a tumble, and because of hygienic and safety issues. But the thing is, our units are individual units that go to each patient, and they get distributed in different medical specializations. So we're very much riding on all your research and your progress, and that's what has led to our sales to hospitals. And so thank you.
No, thank you guys for doing what you do. Um, you know,
And I'd love to get in touch with Joanne if it's possible. I think right now the model that EMDR we're trying to see if it's something that could work is addressing PTSD or trauma right in the peritraumatic stage. So PTSD takes like a month to 6 months to come into your system, and my theory is that if you allow people to process it at the hospital EMDR, then you're able to reduce PTSD. And so, as you know, about 15% of people who leave hospitals develop PTSD. And so, can we address that in a very low cost manner? It's what we're trying to do. And we're talking with the VA as well, and the U.S. Air Force wing, a medical wing as well, if we can help reduce well, we're just in talks right now. We're really being careful about it, but we'd love to, if I can send you some of how our design model works and see if it's of interest to you. For each headset that we
having to connect with the right.
Yeah, that'd be great. For each headset that we sell, we donate one. So we've just been donating to VA, to foster care, and so we have this kind of model where it's kind of a win-win. But I'd love to just send you over our design as the design document, and if your colleague Joanne is interested, I'd love to. Our team is we have a nurse anesthesiologist in our team, and she did her PhD in VR and its use in reducing the need for opioids and so forth. But yeah, Tammy, she works in the field and she does that. She writes the protocols. So if we can be of help in your research as far as protocols, and we'd love to help as well. Thank you.
Awesome. Thank you. Thanks for connecting, Alan.
Wonderful. I think we can leave it there. Rohan and John, again, thank you so much for this. This was wonderful. I already can see all the progress you made since we last talked, and so much more robust. You're really building with VR at the core now.
So it looks like that's
cool.
A wrap, John. What do you think?
Sorry, I was just on mute again. Yes, this was wonderful. Thank you again both so much for this talk. I can see so much progression from the last time you came to the Brigham. You're really building VR at the core, so I think that's wonderful. And yeah, I think that's a wrap. Finally off mute this time. Thank you so much, and we'll see you back on the AMXRA side.
Cool.
Thank you.
Bye,
Thanks so much for
Have a
having
good
us.
day.
It's an honor to be here.